measuring hospitalizations and identifying facility providers. And I know there were questions about it this morning. So I'm hoping that there's lots of interest in this. Let's see. Okay. We're going to be talking about what hospitalization information is available for Medicare Advantage beneficiaries. And then as people were understanding, the MedPAR is a file that's been released for a while that does have Medicare Advantage beneficiary information. And then there's also inpatient encounter data that we have. So we'll be comparing those and trying to understand more about what's included in both. So as a review, the inpatient encounter file is released as part of the encounter data. It has that file structure where if you were to request the inpatient encounter file, you would actually receive multiple files, the base file, revenue center, condition code, occurrence, span code, and value code. And we will be talking about that a little bit later. And then the MedPAR file, which actually includes both inpatient hospital and skilled nursing facility stays. And it also includes information for both fee-for-service and Medicare Advantage beneficiaries. Now, historically, there's been concerns about under-ascertainment of managed care beneficiaries in this data, and we'll talk about that in just a minute when we talk about that file. So we're going to start with the MedPAR file and just kind of go through what is this file, who's included, what are the key variables, and what are some of the caveats associated with it. So services included in the MedPAR, when we talk about hospitalizations, we don't just mean acute care. It can include inpatient rehab hospitals, inpatient or psychiatric hospitals, or others, or inpatient psychiatric or other specialty hospitals, long-term care hospitals. It also includes information from special units within short-term acute care hospitals. So sometimes within a hospital, they will have a unit for inpatient psychiatric stays, or a unit that takes care of people who need rehabilitation. Now, these are somewhat a artifact of the way that CMS fee-for-service pays for hospital stays. They have different payment systems for these different types of services, and that's why the special units within a short-term acute care hospital will need to be identified separately because they will have a different actual payment system. Now, the MedPAR actually does also include skilled nursing facilities. We're really focusing on hospitalizations here, so non-skilled nursing facility MedPAR stays, but just be aware that if you were to request the MedPAR, you would be getting both skilled nursing and inpatient data. And the MedPAR is actually it's meant for rulemaking. It's a policy-related file. CMS for a long time now has been creating this based on what they receive from providers in order to help with the rulemaking process. So that's one thing to keep in mind as what the MedPAR is. So the MedPAR is a calendar year file, annual, goes January 1st through December 31st. Hospital stays will be included based on their date of discharge, and skilled nursing facility stays are included based on their admission date. The way I kind of remember that is, you know, if you're interested in rulemaking and you're trying to follow a patient, it's kind of helpful to have, you know, if they're discharged and admitted, you'll get they'll be in the same calendar year. But something to note, so if someone is admitted December 30th and they are discharged January 2nd, they will show up in the January calendar year file, not in the December calendar year file. So the MedPAR population, it's Medicare beneficiaries that are receiving hospital services, and it is derived from claims that are sent from the provider straight to CMS. So even for Medicare Advantage, there's no stop off at the Medicare Advantage organization. It's going straight from the provider to CMS. Why would a provider send information to CMS? The reason is because CMS sometimes wants to pay these hospitals or make a calculation based on the Medicare beneficiary stays at that hospital. So they might be counting Medicare days in order to adjust their policy payments. For indirect medical education, they actually pay the hospital based on the what the fee-for-service payment would have been, the fee-for-service IME payment would have been. So they need to have information about whether or not, or you know, that a patient was seen and what their needs were. Now, some hospitals don't receive these payments. They may not receive a disproportionate share payment because they don't serve a disproportionate number of uncompensated care. Some don't have teaching programs, so they're not using residents to care for their patients. So that is one of the reasons that we've always been a little bit concerned about saying, oh, you can use this file to study hospitalizations in the Medicare Advantage population. Certainly people have used it. It's much better used as a denominator of hospitalizations. One of our faculty members has done exactly that. They've said, we've identified these hospitalizations in the MedPAR and we're going to link that to their post-acute care use. It might be an incomplete numerator though. If you were to say, I want to know how many hospitalizations there are in the Medicare Advantage population, you may not be getting all of the stays. Oh, sorry. Just to highlight that there are under ascertainment concerns. And that's one reason why some of you might be like, I never even knew that the MedPAR included them. It wasn't something that was kind of widely advertised. And, you know, we've sort of, in our previous fee-for-service studies, have just said we're not interested in those Medicare Advantage people, you know, we kind of recommended just taking them out. So how could you identify MedPAR hospital stays that are paid by Medicare Advantage organizations? Oh, and I see there's a clarifying question. So if there's a Medicare Advantage hospitalization that's included in the MedPAR, you can be pretty sure that it happened. If you're looking for hospitalizations for any Medicare Advantage patient or Medicare Advantage beneficiary, you might be missing some if the hospital didn't have any reason to send that on to CMS. So if they weren't receiving any policy payments, they're not required to send the bill to CMS. So that's why we kind of say, well, if you use that as a denominator and then look at like post-acute care use, that might be a better use. But now that we have encounter data, we can kind of look at this and we'll talk more about that at the end. So how would you identify these stays? There's actually, the MBSF is kind of always what we recommend as the best source for enrollment information. If we compare, there's actually a few different variables on the MedPAR that will describe this. There's a claim type code, GHO paid code, so whether a group health organization pays it, or whether this is an informational encounter submission. And they're collected for different reasons on the stay, but just to note, if you look at the y-axis here, we're talking pretty good agreement between these and the MBSF, even though it looks like they're a little bit different. In general, there's very good agreement. The encounter switch didn't actually come on until 2011, so that's one difference to note. And if we look over time, you can see that the total MedPAR stays with an HMO indicator have been increasing over time, and that correlates well with the increase of the Medicare Advantage population. So really, they're good indicators. The encounter switch is a great one if you're looking after 2011. So the unit of record of the MedPAR, you may have been noticing that I keep saying stays instead of claims. And part of this making this policy-making file was they rolled up claims into stays. If you're looking at inpatient fee-for-service data, almost, I don't know, I think it's like 98%, maybe 99% of stays only have one claim submitted. So there's not too much of a difference, but some stays do actually have more than one claim. Sometimes this happens if maybe the stay crosses the hospital's fiscal year. So they close out the claim at the end of their fiscal year and then open a new one at the beginning of the next one. Or if it's a very long stay, the hospital might send an interim bill and then send a final bill later. So even within fee-for-service files, you might find more than one claim that's associated with a stay. For the MedPAR, they've done all the work for you. They've rolled them up to a stay level file. If you remember Becky talking about the revenue center file that comes with the encounter records, it's similar setup for fee-for-service, and there can be multiple lines. In order to bring that up to one line per stay, sometimes these are summarized. It may be summarized by summing charges. There may be a flag that's created based on whether or not something's present in one of the detail files. Or sometimes the information is like, this is just, these are the diagnosis codes from the last claim of the stay. You can get information as to how these are calculated in the MedPAR data documentation in the code book. So if you're curious about that, but just to note that it's one line per stay. The key variables that people tend to be interested in are the, if they want to identify the clinical care that's used, there are 25 diagnosis codes. There, in addition to those 25, for each of those, you can know whether or not that diagnosis code was present on admission. Mechanism of injury codes have another section within the MedPAR data, so you get a lot of diagnosis information. You get ICD procedure codes that will cover major procedures that happen within the stay. One thing to note for these, sometimes I've in the past been interested in looking at something and I find an ICD procedure code for it and I'm really excited to look in the hospitalization data and it's not there. And that would happen when the procedure doesn't necessarily change the DRG. Now for Medicare Advantage, maybe that's not as much of an issue, but it's really major procedures that we tend to see in the hospitalization data. It's a surgery or something like that. And it does include a date of service for each procedure. And the MedPAR data includes the diagnosis related grouping. Now, it doesn't have a separate derived DRG field because there's only one DRG that's calculated, and it's calculated for everyone. It's calculated based on what the diagnosis codes are, the procedure codes, and then other factors that might influence the DRG are like whether the patient died during the admission. I think some of them do take the patient's sex into account. That's a calculated field by CMS. And so it's calculated both for those stays that are submitted for the Medicare Advantage stays. One thing to note though, the hospital isn't being paid that DRG amount. That DRG amount is calculated, but we don't know what the Medicare Advantage organization actually ended up paying for the hospitalization from the MedPAR. So again, I mentioned that you can get some information about different departments that may have been used, whether they have an intensive care unit charge amount, whether they have an emergency department charge amount, excuse me, that should say charge amount. Now I bring up the emergency department. In fee-for-service, we often tell people if you want to make sure you're getting all emergency room use, you're probably going to want to look in both the outpatient file, because the emergency room is an outpatient department, and the inpatient file. Because of the way Medicare pays providers, emergency room use gets bundled up within an inpatient stay. So they'll have one bill associated with their inpatient stay, which will include their emergency department stay if they were admitted through the emergency department. For Medicare Advantage, in the encounter data, that may not be the case. You may find more outpatient bills for emergency room use that are followed by an inpatient bill for stay. So just note that that is expected to be a little bit different. I think when we looked at all of the ER visits in the outpatient, about 20% we did find an accompanying bill. We were pretty sure that within 3 days at least that they were admitted. You may also find summary fields like day counts. So you could see how many days did they spend in the intensive care unit if that was something you were interested in. Now, if you're interested in studying providers, the MedPAR provider number that's provided on the MedPAR takes the CMS certification number. Some people were talking about that earlier, and removes the special unit code and brings it out into a separate variable. The CCN is really useful for understanding who's getting paid because it has information embedded within it, which lets you see what kind of care is being provided. Let me go on to the next slide to be a little more clear about what the CCN is and what the provider special unit codes are. But let's see if I can. And I should note too, it's the MedPAR provider number. It's not exactly the same as the CCN, although you could put the special unit code back in and create a CCN. So the CCN is a 6-digit CMS certification number for a facility. The first 2 digits are the provider's state code, and then the final 4 digits, you can use the ranges of those to understand what kind of hospital is billing. Is it a psychiatric hospital? Is it acute inpatient in general? Now, if it were a special unit within a general acute inpatient setting, then you will find that the 3rd digit is replaced with a letter. So if you see the letter M in the 3rd digit, that's a psychiatric unit within a hospital. When they create the MedPAR provider number, and you can look in the MedPAR documentation for a little more information on this, they take that out and they replace it with a 1 or a 0, because those are the most common numbers for acute general inpatient hospitals. So you could recreate the CCN using the MedPAR provider number, but just note that those are available. And again, these special units and provider number ranges are important because it's telling you how CMS is calculating the payment for that particular provider. There's also an organizational NPI on the MedPAR. This is a 10-digit number. It comes from the HIPAA rule that each organization should have a National Provider Identifier. It should uniquely identify the institutional provider certified by Medicare. It's intelligence free, which means that you can't tell based on any one of the digits what type of provider it is, or what state it is. They're all assigned randomly. When it is on the MedPAR, it's from the first claim included in the stay, but I think they do tend to roll up by the CCN. Now, the CCN and the NPI don't crosswalk exactly. It wasn't like, oh, they had a pre-existing CCN and every CCN got an NPI associated with it. It's actually a different application process. They're pretty close, but they're not 100%. So in the 2019 MedPAR, there's a slight difference in the number of CCNs and organizational NPIs. Most NPI, or they're 1.7% of NPIs are associated with more than one CCN. Sometimes we have the case where a single CCN is associated with more than one NPI. Now, the provider numbers are also really useful, not just for maybe you want to aggregate by provider, but you can get more provider information. The CCN can link to a lot of different CMS resources. So the provider of services file, which can give you information like based on their surveys. So what is the bed size, that sort of thing. It also can link to the hospital cost reports. They're also called the healthcare cost reporting information system. The NPI, on the other hand, you can get more information about the provider using the National Plan and Provider Enumeration System. Some people call it the NPPES or the NPPES. That's a file that you could use. It's got organizational taxonomy. So you could say, you can use it to sort of say what type of provider is this, and we'll talk more about that later. We're going to move now to talking about the Encounter inpatient files. So these are newly released with the Encounter data. These originate based on what the plan is sending to CMS. And again, it's under that mandate and for risk adjustment and all of that. This will be Medicare Advantage enrollees only. And it will be any Medicare Advantage beneficiary for whom an encounter or a chart review was submitted by the plan with this claim type code that indicates that it's an inpatient stay. Services that would be included in the inpatient encounter data are very similar to what you find in the MedPAR. So short-term acute care hospitalizations, inpatient rehab, so any specialty hospitals, long-term care hospitals, and again, special units that might be within a short-term acute care hospital and critical access hospitals, but it does not include skilled nursing facility. Skilled nursing facility stays have their own separate file within the encounter data. The inclusion dates are just slightly different than the MedPAR. They're included based on their claim through date. I would say most of the time the discharge date is going to match the claim through date, but there might be exceptions. But it's again a calendar year annual file, but the claim through date is going to determine which calendar year it falls into. So the structure of the institutional encounter files, Becky talked about this already. Just remember that you're going to get multiple files. The files are going to have different sorts of information. When I was doing mostly clinical outcomes research, I was mostly interested in the base file and the revenue center file. I use the revenue center file to say, oh, this emergency room may be used or something like that. And the base file gives you lots of information about who the provider is and what the diagnoses and procedure codes, admission and discharge date. But the other files might be useful. We have a student now that's working on workers' compensation, and they're finding that if you use some of these files, you can tell whether or not you can get information about whether or not this was paid under workers' compensation, for example. There's a question about whether the hospital type is indicated in a separate field. So I'm not sure if this is specific to the encounter data, we can talk about it in a little bit. I'll talk about the identifying providers. Remember, the encounter data might also have, more than one stay associated with, or more than one record associated with a stay. So that's another difference between the MedPAR and the encounter data. You're going to have to do a little bit of investigating. This was just one example that I kind of just opened up the file and quickly found this isn't a real example. I've changed, dates, and no, it's not the same Benny ID or org NPI. But this was an example that I actually found. So the claim from and claim through date were the same on both records. They both indicated admit through discharge. They both indicated final action. But when I looked at the claim admission date, I was like, oh, maybe this one wasn't quite right, where the claim admission date does not fall between the claim from and claim through. So these might be clues to help you as you are trying to decide, if I were just to have run a, just run a count of stays for based on beneficiary and date, I may have counted this as 2 stay, or maybe not date, because date wouldn't have included both. But if I just was saying, oh, how many stays are there for each beneficiary, I may have counted this twice. So just, you can be a little bit careful. So there's a question about what claim from and claim through indicate and how it's different from admission and discharge. Now, I'm going to talk about fee for service because that's where I'm most comfortable, and I assume that a lot of it will translate to encounters. So the claim from is when services started. So they're going to say, like, in prospective payment, for example, if you were to say have an emergency room stay for chest pain, and then you were admitted 2 days later for MI or something for related to the chest pain, those should be bundled together. That's one prospective payment. They're saying hospital, you maybe should have, like, that's considered part of the same problem for that patient. In that case, the claim from date will actually precede the admission date. So that would be one reason. Like I said, I think claim through and discharge will often be the same, although if, as I mentioned, if a hospital breaks a stay across multiple claims, the claim from might actually precede the discharge date. So that's just something to note. So the claim from and claim through is kind of where what dates this bill covers, where admission and discharge is actually just trying to give information about the hospital stay itself. And so can you distinguish between an acute stay or a hospital stay in the encounter data? Stay tuned. We're going to talk about that. Okay. So for encounter, the encounters are a description of the service, and they're sent from the plan to CMS, and they're not a bill, which is different than fee for service. And they're submitted for the calculation of plan payments from CMS, which is why we see things like chart review records that may add or subtract diagnoses, but usually add. And they're describing utilization. Sometimes you may find more than one record per stay, and we don't have a lot of information about. Sometimes, maybe we would have been able to see a denial or something like that in the fee for service, and we unfortunately don't have that in the Medicare Advantage. So there is going to be some level of work that you might need to do if you're trying to count stays. The key variables are going to be very similar, though, for what you might find in the MedPAR. You have the diagnoses, 25 per record. For procedures, it's only 13 per record, but there are very few stays that are going to have, more than 13 major procedures. So it's not going to be that different than what you find in the MedPAR. And then just remember that you can find chart reviews that will have diagnosis codes that could possibly add to a record as well, if that's something that you're interested in adding, which is a question mark depending on your goals. There are DRG variables, again, on the encounter data. Becky talked about this. The prospective payment system has, uses the diagnosis procedures, other factors to calculate. Medicare Advantage organizations have no obligation to pay under prospective payment or to use the same rules. They can pay their providers how they want. So the claim DRG, that's what was collected on the encounter, may not be filled. CMS does go ahead and calculate a DRG based on the claim inputs, the diagnosis procedures, whether there's a death during the hospitalization, the discharge status. So we can find that, and that's something that will be akin to what we see in fee-for-service data.
Do they use the chart review diagnoses when deriving it or not?
No, they would only use what's on the service record to do the derived DRG, I believe. The chart review ends up mattering for the risk adjustment payments later. So, you know, you can get information about the care that was needed during the stay. Again, in this case, unlike the MedPAR, you would have to go through the revenue center detail, maybe create your own flags or however you want to sum it up. Now, in terms of revenue center detail, how the hospital reports this to the plan, and then the plan reporting it to CMS, that may vary according to policy. So just note, you know, it may be possible that you're not going to see it for every, maybe the managed care plan never collected a certain revenue center, for example. So that's something, no reason not to use it, just be, as you're using it, be careful and look, you know, don't necessarily assume if you don't see a revenue center that, you know, if it's always missing for a particular plan, you might be a little more suspicious. Key variables, you can identify the managed care organization on the record itself also. So you could use that to link to the plan characteristics file, for example. Just remember to use both contract and plan number, not just the plan number if you're wanting to get more information. Now, as we've talked about, the encounter data only has the organizational NPI, the organization NPI. You can't use the structure of what's included in the NPI variable itself to determine the provider type. And there is a field on the encounter data that is called the organization taxonomy code. It's not routinely filled. This isn't something where CMS is taking the org NPI and filling it in. It's based on what's reported, at least that's my understanding. So, so you don't necessarily get the taxonomy. If you do though, then you can find, it's the National Uniform, oh no, I've lost it, the NUCC taxonomy codes. Otherwise, if it's missing for you, you can link it to the NPPES, the National Plan and Provider Enumeration System, and it's a public use file, so it is publicly available. And you can use that if you want to separate provider types. Remember, some of the provider type separation that is done for fee-for-service is an artifact of payment. So, so you know, it's not necessarily that provider is getting paid in the same way as they would have been in fee-for-service from a managed care organization. And you can have multiple taxonomy codes per NPI, although I think, you know, in general, there's one. So what it might look like, there's a taxonomy group. So the group might be hospital. And then there's a part of the taxonomy is the classification. So you, within the group of hospital, you might have a general acute care hospital or a long-term care hospital. And then there's also built within, you can have a specialization. So that might tell you whether it's a critical access hospital or a children's hospital. Another different group that you might see is hospital unit. So this we would assume is a, you know, within an acute care hospital, you have a psychiatric unit or a rehabilitation unit. That's how they've requested their own NPI. Again, the NPI should be specific to a type of provider. And then for nursing and custodial care, we did look, just because you can find that would be something like you might be able to find a skilled nursing facility, and that could have a pediatric, you could have a special pediatric skilled nursing facility, for example, that you'd be able to identify in the taxonomy. So just a quick poll to help review. Go back to our polling questions. So how does the MedPAR differ from the inpatient file? And then which file do you think you would choose if you were wanting to study? All right, I'll give a few more seconds. Let's do 10 more seconds. Okay, so how does the MedPAR differ from the Encounter inpatient file? And some of these might be a little bit cryptic, but so the MedPAR does differ in that it includes skilled nursing facility stays, whereas the inpatient encounter file does not. Now you may be thinking, well, you still can get SNF information, and you can, but you would have to request a separate file, the encounter skilled nursing facility file. The provider identifiers are also different. Now I see a question in the chat about why are they different? Why don't you see a MedPAR provider number on the encounter data? And then the follow-up, is there a crosswalk? So for the first question, the CCN is communicated to CMS for those fee-for-service hospitalizations because they're alerting CMS to which payment policy they fall under. So inpatient rehab is paid differently than just inpatient, acute inpatient stay, the inpatient prospective payment system. So hospitals have figured out a different way to communicate to managed care organizations. Again, they don't necessarily have to pay different hospitalization types differently. They probably do, but they have their own system for figuring that out. Likely part of that is using the org NPI. Now, you might wonder, why can't they just use a crosswalk and put the CCN on the encounter data file? And there isn't really a crosswalk because it's not like, again, it's not like an NPI was assigned for each CCN. They're pretty close. And so we'll talk a little bit about a crosswalk in the next few slides. But and then one question was, does the MedPAR only include skilled nursing facility stays for fee-for-service, and MA patients would only be in the MedPAR for short-term acute care stays? So I think that's mostly true. But the when I was looking through the information indicators, you can find some claim types that are, so what I listed were 61 through 64, and those are all inpatient claim types. 20 and 30 are skilled nursing facility. And if you cross-tab that with informational encounter switch, you do find some. I don't have the expertise to know under what circumstances a skilled nursing facility might include an information stay. So stay tuned, but that could be something to look into. Oh, swing beds, that's actually a really good thought. Back to our poll. So provider identifiers are different. The reason for submission, that was kind of a cryptic one. The reason that that things are submitted that end up in the MedPAR is for those policy payments. The reason that we see hospitalizations from the encounter side is basically a requirement for the plans to submit the services in order to calculate risk adjustment. So they do have different reasons for submission. The unit of record is different. So the MedPAR is stay level, whereas the encounter data is service level, but includes service and chart reviews. And then the dates of inclusion are slightly different as well. One is based on discharge date and one is based on claim through date. And then which file do you think you'd use? So a bunch of people are saying encounter inpatient file. You can feel more confident that if there's a Medicare Advantage service, it should be submitted by the plan. That being said, there have been questions over time as to how complete submission is. So some people say the MedPAR is stay level. It's really attractive in terms of the ease of use. But again, there are some under ascertainment concerns. So what we'll do in the next section is we'll kind of compare which stays do we find in both. How do we navigate CCNs and all of that. So we can go through that. And I guess I never explained, if people don't know what swing beds are, if I have it, they would be like a hospital bed that's billed as a skilled nursing bed. So if it's especially maybe happening in smaller hospitals where I used to work in a very rural hospital that had a nursing home attached to it, and the census was almost always 0 unless there was a mom or a baby. But sometimes the skilled nursing facility residents would require an increased level of care, and they could go into a swing bed of the hospital. And then that could be one way that swing beds work. So again, it's another another type of system. So we wanted to do a MedPAR encounter data comparison, and there have been others in the past. So MedPAC has done some, and we included some of those reports. Jia Zheng, who's also on the ResDAC faculty, has a couple of papers out looking at comparing the MedPAR and encounter data. So how do we go about doing that? The very first thing we did was limit to short-term acute care hospitals and critical access hospitals. In order to do that, though, we created a provider CCN to NPI crosswalk using what was available on the MedPAR file. So assuming that the org NPI on the MedPAR stay is associated with the CCN on the MedPAR stay as well. So we used that in order to say, well, if we had a CCN, how would we characterize them? And then we also linked out to that NPPES taxonomy in order to compare what we would have assigned based on our crosswalk with the NPPES. And then we had to do some deduplication of the encounter stays in order to get to a stay level file, and some rolling up to get to the stay level file. And then we could look to see, do we think this is the same stay as what we see in the MedPAR? Which ones are we missing? So we matched those two. And then for stays where we did have a match, we were able to link to with the CCN match anyway, we were able to link to the cost reports and get some more information about those hospitals to try to better characterize maybe who's missing from the MedPAR. And so we'll talk about that here. So to match the encounter and inpatient data, we first excluded the chart reviews and the inpatient data, right? We weren't necessarily concerned about matching diagnosis codes and all of that. We were really looking at just, did a stay happen? And when did it happen? So we deduplicated using the beneficiary ID, claim from date, claim through date, and organization NPI, and aggregated the stays using the beneficiary ID and admission date. Now, about 2% of stays were missing admission date. I wish this is true of every administrative data source I've ever worked with. There's things where you're like, how is that possible? And yet, generally, like 1 or 2%, we just sort of say, we don't know, but it's there. And that's always, as our former PI, Beth Fernig, used to always say, like, most of, like, you can get 95% of the way just doing a simple thing. And then you're always going to have 5% where you're kind of scratching your head and saying, how do I do this? Because it's not what I expected. So and that usually takes you the bulk of the time. It's adjudicating those things. That first part didn't take you very long at all. Okay, so in the MedPAR, we limited to the encounter stays. At one point, we were a little bit curious, what happens if we remove that? But by and large, we find, the encounter stays are characterizing Medicare Advantage beneficiaries. And then we limited to short and long stay records, which means that we didn't include the skilled nursing facility records. Then we matched by the beneficiary ID and the admission date, and we gave it a few day plus or minus. And that's something that when you're working with administrative data, you have to decide how much of a cushion you want, but we do find sometimes that dates are a little bit funny. So we did do that inclusion, and really, I don't remember the overall difference. It wasn't that different if we had less, but we wanted to be as inclusive as we could. So we weren't kind of unnecessarily saying that a hospitalization was not there when it, or did not match when it actually maybe did. So when we tried to assign the provider type to encounter stays, what we have here is the consistency between what we found in the encounter data, NPI, when we linked it to the NPPES, and what we found in the MedPAR CCN. So you can see that a lot of the provider categories are pretty good. They agree pretty well. If we just use the NPPI to characterize with the, just use the NPPES to characterize based on NPI, is very similar to what we kind of built with our crosswalk for the stays that we found in both files. Some were harder than others, especially kind of the special units that are contained within acute care hospitals. But we do find that the NPPES might be a pretty good indicator for some types of facilities. Now, how many stays were we able to match? When we look at short-term acute care and critical access, if we combine both files, we have about 5 million stays. The ones that we found in both files is about 4 million. So it's not perfect, and there are stays in the MedPAR that we didn't find in the Encounter Inpatient, and there are stays in the Encounter Inpatient that we didn't find in the MedPAR. Now, neither of these is really a gold standard, right? We were concerned about the under ascertainment in the MedPAR just based on hospitals not needing to submit a record. We're a little bit concerned about encounter stays just from as Medicare Advantage organizations get more used to submitting their services. It's improving, but there've been ongoing concerns about, are we getting everything? So when we look at trying to look over time, how many were we able to match? Because we don't have a gold standard, we kind of went both ways, and we said how many MedPARs match in the encounter data, and then how many encounter records match in the MedPAR data, and then how many, if we combine the two, how many are we finding? So we have MedPAR having a slight edge on the number of records, but we're and it has improved over time, although we're looking at kind of 88% versus almost 90%. So a little bit of improvement. So there has been like I said, there's been other work done on this. MedPAC, their March 2020 report to Congress, which I do have in the course page as a resource if you wanted to look at that. They found an 81% match in 2017. Our results were limited. They didn't, as far as I know, do any limitation to hospital type. We were looking at short-term acute care hospitals and critical access hospitals for that particular comparison. And then, as I mentioned, Jia Young had done a similar analysis for encounter data in 2015. She found about 5% of MedPAR stays that weren't found in the encounter data. She did do some exclusion based on the type of plan, whether it's a cost or a demonstration or a PACE contract. So that might explain some of the differences that we found. But by and large, we've got pretty similar findings. So for the ones that we were able to assign a CCN to, so the stay was found in both, we were able to, or they had an organizational NPI that we thought we knew a CCN for. We then looked at how often, or what are the kind of the characteristics of the hospital that might be associated. And what we found, if we look at an urban hospital versus a rural hospital versus a critical access hospital, which is a special kind of rural hospital, really, we do find that it matters. Critical access hospitals have the lowest amount of MedPAR admissions to encounter admission ratio. If we take the whole denominator and we say we're looking at everyone that is either in the MedPAR or the encounter data, we have that as a separate column here, so you can kind of get an idea. Critical, so it's not unexpected that we would find this. We looked for this in particular because rural hospitals and critical access hospitals, they may not have some of the policy payments that, or they have their, critical access are paid under a different policy system. So they may not need to submit the claims, or they may not have the resources to make sure that every claim is submitted. So we did find that. We also looked at whether or not in the hospital cost reports, there was a receipt of disproportionate share payments or indirect medical education payments. We do find that if they receive both, that's the highest likelihood that we're going to find something in the MedPAR, but it's not a slam dunk. There were some hospitals that received both types of payments where we did not observe the admission. We found it in the inpatient encounter, but we did not find it in the MedPAR. So, so that's one thing that we can't fully explain, but we do know that that we don't necessarily see them in the MedPAR. Also, again, hospitals, their size might indicate the number of resources that, or the amount of resources that they have to be submitting some of these shadow bills or information only claims. And the largest hospitals are the most likely to submit. And then the tercile of admissions covered by Medicare Advantage. For this, we looked at encounter admissions over the number of total admissions that we found in the MedPAR and the encounter. And again, if they have more managed care use in their hospital, we did see that they were more likely to have a MedPAR claim associated with, or a MedPAR stay reported to CMS. Now, from the other side, what about these stays that are in the MedPAR but not in the encounter file? We were wondering if maybe this was related to plan. We didn't spend as much time on this, but just to give you an idea, if we kind of look at the top 20 Medicare Advantage parent organizations by membership, and this is total membership at the bottom, and then the percent of hospital stays that we find that are in the MedPAR but not in the inpatient encounter. You know, a lot of them are doing pretty well, but there is some scatter, and it's not necessarily related to the size of the organization. So I think, you know, you may say, I'm going to take a look and I'm going to limit it to certain large plans, or you can do that. But that's, again, this wasn't something that we spent a ton of time with, but we were, you know, kind of hoping that maybe we'd see plans that weren't submitting at all, and that actually wasn't the case. There were some that were doing better than others, though, as you can see. So in terms of discussion, we have a match between the MedPAR and the inpatient encounter data 85–90% of the time, and vice versa, and it has improved a bit over time. If you're really concerned, you know, you want to use the inpatient encounter data, that's what it's there for. We want to start using it, but we don't have CCN, and that's troubling us. The NPPES does a pretty good job. Again, it's probably more difficult for the special units within an acute care hospital, but you can use that to characterize the type of stay that we're finding in the encounter data. Larger urban hospitals who do receive Medicare policy adjustments and serve a large proportion of Medicare Advantage beneficiaries are more likely to appear in the MedPAR. So, you know, you may say, that's actually, you know, who I'm interested in, that's the bulk of what I'm doing. You know, you may feel comfortable with the MedPAR there too. And the MedPAR stays that don't appear in the encounter data do vary by plan. So that's something to keep in mind when you're doing any analysis. We recommend kind of looking by plan to see to understand more of what you're seeing. Oops. And I think that's all I have. So any questions that we can answer, discussion we can have? Let's see here.
I think I've addressed all the questions in the chat, but if
Excellent.
I haven't, people can feel free to type it again in the chat or even unmute at this stage, since we're answering questions.
Thank you. And I see there may be one about NPI CCN crosswalk, and it doesn't exist. I think if you search for it, you find something that looks super promising, but in the end, it doesn't have, I think that's based actually on the NPPES file itself, where they can report a CCN, but unfortunately it's not reported very often. So that's not terribly useful. But if you do have any fee-for-service data, you might be able to try your own crosswalk in terms of there will be an organizational NPI, right? Yep. So there'll be an organizational NPI and a CCN on the facility claims. So you can try to do a crosswalk there if you have the fee-for-service data. Again, like, it's hard. I don't think people are releasing a crosswalk because it's not exactly something that crosswalks. Yeah, Christopher, do you have a question?
Yeah, hi, sorry, that was I who had asked the previous question. So I
Mhm.
guess when you had mentioned your crosswalk in your presentation, it was more really an internal crosswalk that you guys had. Okay.
Yes, yeah, I
Yeah, because
apologize.
I've also tried to do that in the past, and oh my God, it's such a mess. Okay, thanks a lot
Yes,
for that clarification.
yes, sorry.